Hello, everyone. My name is Steven Stocker, and I'm the Digital Media Coordinator for SNO. The following is our first podcast in a series to help give you the information to hopefully get you into a surgical residency. So, for our first episode, I sit down with fourth year Rossi and SNO's very own event coordinator, Mr. Nathaniel Wolff, who's here to talk to us today about third and fourth year rotations. So, without further ado, enjoy. So today I have with us Mr. Nathaniel Wolff. Nathaniel is currently a fourth year student, just finished up his clerkship at Jamaica. So Nathaniel, go ahead and tell us a little bit about yourself.
Yeah, so thank you, Stephen. So, like Stephen said, my name is Nathaniel Wolff. I'm a fourth year student that just finished all of my course, thankfully. Um, I come from a little tiny town called Bunkie, Louisiana, really rural, small, kind of medically underserved town. So, adjusting to life here in New York City was definitely a change, but a change that I really enjoyed. It was great. I've loved my experience here, and I can't wait to share my experiences. Um, my goals long term are to hopefully, like most of you listening, is to get a surgical residency in general surgery. And then after that, I'd hopefully like to pursue a fellowship in either critical care surgery and trauma, or who knows, I could find something totally different that I like,
Right.
but that's kind of the plan for now. So yeah, I'm excited to talk to you all about kind of what third year cores look like, what planning for your fourth year looks like, because I know that it's a really mysterious topic that isn't addressed a lot. And I know that I had to figure a lot out of it out myself. So I'm excited to be able to guide you guys through this journey.
Excellent, excellent. And just so we're clear, my name is Steven Stocker. I'm a third year Rossi. I'm the digital coordinator for the SNO Club here at Ross. So just a little bit, I forgot to mention that, glossed over that in the beginning, just so we're aware of who's who. So first thing, Nathaniel, I wanted to ask you is because I'm also at Jamaica Hospital. So I just started in July, end of July with internal medicine, and now just finished my second week of surgery, which is it's just a lot of fun. So wanted to kind of ask you, why did you ultimately land on Jamaica Hospital?
Yeah. So I was a member of the cohort where COVID was still kind of a big deal, and we were dealing with some of the backlog of clinical rotations from people that had been unfortunately ousted from their clinical sites due to COVID. So we didn't have the typical, like, hey, send us your top three options and we'll try to put you in one of them. We kind of got what we were dealt. So right after I finished
Voluntold.
step,
Yeah.
yeah,
Yeah.
exactly, voluntold.
Yeah.
So right after I finished step one, it was kind of crazy because I submitted my step one score, and then the next an email saying, "Hey, and I was like, "Holy crap!" Like that's really quick, but also that's really exciting. I was ready to dive into the clinical curriculum, get some experience, get my hands dirty, so to say. So I initially was hesitant to choose Jamaica because being someone from a relatively small town and never really living in a huge city like New York, that was really bombarding.
Yeah.
And I had to do a lot of soul searching in that 24 hours that they gave me to decide, hey, do you want this or not,
Right.
on whether or not this was the right move. I'm sure that you can share that sentiment, Stephen, of like having to pick up and move somewhere totally different. And I'm sure we can all share that sentiment because we all,
Yeah.
most of us at least, ended up having to pick up, go to the island for a little while. So it was kind of the same experience.
Yeah. No, it was.
But what I did that really made me feel more
Oh no, go ahead. Go ahead. Keep going.
the two of us. Yeah. So what I did that really helped me to decide that Jamaica was a good choice for me was I actually reached out to a friend of mine who we submitted our step scores on the same day, and he had also gotten placed at Jamaica. So I said, hey, all right, at least I know one person. I can go in and have at least one person that I, can count on, can trust. And, shout out to him, my roommate, Daniel Wells, over the past year. He was an amazing support system for me. So it was nice to have that one other person. And then coincidentally, when I had first started attending Ross, I ended up following a graduating Instagram who was actually around. So he and I had never actually like physically interacted. We didn't know each other very well, but I just reached out to him and was like, "Hey, I just got placed here. You're the only person I know that could give me any sort of information. What do you think?" And he was a wealth of knowledge and really cemented my choice that Jamaica was the place that I wanted to be, especially wanting to be a surgeon, being that they're a level 1 trauma center, they're a relatively busy hospital. So I knew that I was going to get the experience that I wanted and needed there.
Yeah, no, definitely. That's sort of been my experience at Jamaica. Is I've heard, different things about different clinical sites, but one of the overarching things I've always been told about Jamaica Hospital, and not just Jamaica, but it's a very hands-on experience there. And if you tell the people that you're under, your attendings, your surgeons, that you're interested in medicine and doing medicine, you're interested in doing surgery, they give you a lot of autonomy in terms of decision making and seeing patients and getting hands on. So, I've not only been scrubbed in on procedures, I've actually been like an active participant and got to, do a lot. This has only been my second week, so yeah, it's been an interesting experience thus far.
Yeah, exact same experience, Stephen, is that looking back on it now, I value the experiences that I had because, like you said, we were given autonomy, we were given responsibility and expected to take an active role on the team, which I really preferred that method of education rather than the like shadowing and that type of thing, because
Right.
I feel like even now at the end of my third year, I'm completely prepared to go into my sub-Is and my electives and perform very well and perform at the level that a first year resident would be expected to perform because of my experiences at Jamaica. And I can say that is normally the case at most of our clinical sites, is that I have many friends that have rotated at other sites that have absolutely loved them, have gotten amazing experiences, things that you would never dream of doing as a third year medical student that took step one basically yesterday.
Right.
Um, that you just get to dive right in and be part of the team. So while I can only speak on Jamaica personally because that's where I was, I can say that as students go into their third year and are making those decisions, most, if not all, of our clinical sites are extraordinary choices, and you're going to receive a great experience.
Absolutely. That's fantastic. The so you went through all of your third year,
Mhm.
which is pretty grueling from what I'm seeing, because not only are you, you have a job, you're
Yeah.
waking up early, you're getting to the hospital early, you're seeing patients, you're learning while you're there, and then the second half of your day, your second job starts like when you get home, whenever that is, and then you have to get to studying, and on top of your studying for your board exam, which you have step 2 coming up, then you also have your shelf exams.
Yeah.
So it's now that you've gone past all of that, what is your fourth year looking like?
Yeah. So let me start at the very beginning of what planning for fourth year looked like.
Perfect.
Planning for fourth year was very daunting. I can only speak from my personal experiences, but once I started third year, we were primarily in like the hospital's care, if you will. We heard, things from Ross here and there, checking in on us, seeing how we were doing. But by and large, like we had to take a lot of our own questions and a lot of our own educational decisions into our own hands,
Right.
which was something that I wasn't quite prepared for. But in retrospect, I'm glad that it worked out that way because I
Okay.
was able to really dig into some resources and find out the things that I needed to do for myself based on my particular situation, wanting to match into surgery, which is a relatively competitive specialty, and knowing my own board scores, knowing what I was working on to be on my CV as far as research experiences and educational experiences and leadership experiences, and tailoring my fourth year around those things.
Okay.
So let me use that as a preface, And then let's walk through a little bit of what your fourth year requirements are before I walk through the choices of electives that I made.
Absolutely. I feel like it's good for us to like talk about these things because I
Yeah,
mean, just yeah, like you said, right after step, you're kind of in this void of like, okay, like what now? And so when it comes to third year, it's already set up. Like if you're on Jamaica track, if you're on, whichever other track that they offer, you're on that track and the rotations are picked out for you. So once you get into fourth year, it's like a big black hole. Like what
exactly.
happens for that? So yeah, take it away.
Exactly. So for your fourth year, and please reference Ross's official requirements via the handbook just to ensure all of these things. This is all just kind of off the dome from what I remember,
Yeah, for sure.
is that you're required to do 42 weeks of elective time.
Okay.
Most electives are 4 weeks from what I've gathered. Of
So
those 42 weeks of total electives, 10 weeks have to be at an ACGME accredited institution. So, for example, if you're going to do a cardiology elective, that means that in order for those 4 weeks to count toward your ACGME requirement, then that hospital needs to have an ACGME accredited cardiology residency program or cardiology fellowship program, excuse me.
okay.
So essentially you have to walk through and make sure that where you're choosing your electives in order to meet that requirement, that they have a residency program or a fellowship program in that specialty in order for it to count.
Okay.
In addition to those 10 weeks of ACGME accredited elective time, you also have to log at least 8 hours of medicine subspecialties or a medicine rotation. So that can be anything from a general internal medicine rotation or sub-I. That could be gastroenterology, cardiology, endocrinology. If I remember correctly, emergency medicine counts for the medicine requirement.
Interesting that
Essentially, it
counts.
can't,
Yeah.
yeah,
Yeah.
it can't be like a surgical specialty. It can't be OB or gyne. It can't be anything like path. It needs to be a medical specialty.
Okay.
And that's just to ensure that you're A, well-rounded, and B, a large portion of our graduates and our residency applicants are applying for medicine or family medicine residencies. So that's going to ensure that you're competent to enter those residency programs and know some basic information before you go into your residency level rotations in those fields.
Okay.
Yeah.
That
So
that
other
that
than
makes sense.
yeah, so other than those requirements, your electives are pretty much free game. So you can go through and pick, choose whatever you'd like to do based on what specialty you want to apply for. So as someone that's applying for general surgery, my my goal was, let me see how I can best set myself up to essentially have a fourth year that looks like an intern year schedule in a general surgery residency program,
Okay.
while also meeting the requirements that the school has for us. So what I did is I went to the American College of Surgeons, ACS website, and they have a wonderful article that I can include the link to, that way it's accessible to everyone, called So You Want to Be a Surgeon. And it walks you through some guidance from ACS on the types of electives you should be choosing, when you should schedule your sub-Is. That way you can make sure to get good letters of recommendation from those sub-I directors. What types of research opportunities you should be trying to involve yourself in, what type of volunteer experiences you should be trying to have. It was a really amazing document and a resource that I referenced often while I
Okay.
was making my elective schedule, because I want to have my fourth year align with a good surgical applicant. So ACS, their recommendations, you would think that they would want you to have a ton of surgical electives in your fourth year.
Yeah, I would imagine, right?
Yeah,
Like,
I was surprised to learn that while they do want you to have some surgical electives and they want you to have surgery sub-Is, they also want well-rounded applicants that have interests and experiences outside of the realm of surgery. So they actually recommended to do some of these same rotations that you need to meet your requirements for like medicine. So if you want to be a general surgeon, a large majority of the cases that you're going to do involve, the GI tract, or they involve the liver or the biliary tree, something like that. So a rotation in GI is always a solid choice because you're exposing yourself to those pathologies in a different light other than surgical treatment, and you're learning about the methods that are available other than surgery for those patients that need interventions.
Yeah, and I think that's a good point because, if your ultimate goal is to, do a general surgery residency and then, particularly stay in general surgery, a big part of your job is going to be making that decision between, like, I mean, do we go forward with surgery or do we treat this medically? And I think it's a very important thing to
Exactly.
bring up. Yeah.
Exactly. They also recommended rotations in things like cardiology, pulmonology, emergency medicine, because those critical care, because those are going to teach you how to deal with your higher acuity patients that have complex medical issues. That, let's just face it, most of the patients that you're going to see, whether you're a surgeon or an internist or a gynecologist, everyone these days has medical comorbidities like
Yeah.
diabetes, hypertension, or chronic kidney disease, what have you.
Yep.
So learning to be comfortable with those medical problems and medical management, especially when you, as a surgical resident, go into your surgical ICU rotation, where you're essentially responsible for every body system that patient has, and managing things like continuous renal replacement therapy, or managing their hypertensive medications, or managing vasopressors. Those medical rotations are extraordinarily important. So based on that information, I scheduled a pretty good balance of surgical rotations as well as medicine rotations. And I can actually walk you through what I scheduled and why I chose it.
Absolutely. Yeah.
So my first rotation that I'm going to do starting in a week actually
Oh.
is, and yeah, a little bit stressful,
Yeah.
is yeah, is abdominal organ transplant surgery. I'm doing that at Cleveland Clinic, Florida. And once we start talking on like actually scheduling and applying for these rotations, I'll get into more of the details on that. Then after that, I'm taking a bit of a break. That way I can, excuse me, break comes later. Then
Okay.
I'm coming back to Jamaica for a month to do a surgery sub-I because I really enjoyed my experience on the trauma service at Jamaica and working with the residents that we worked with, working with the attendings that we worked with. I have a very strong relationship with those people. So I wanted to come back and be with those people again because I felt like I learned so much. Then after that, I'm taking a break to take step two. So I've been studying for that. That's coming up soon. So fingers crossed. Wish
Fingers
me luck.
crossed.
So then after that break in January, I'm then going to Mount Sinai Hospital in Chicago, and I'll be starting on a rotation in pathology. And I
Okay.
chose path because as a surgeon, you will be seeing a good bit of surgical oncology. And I wanted to have perspective onto the opposite side of the operating room. Once we remove this biopsy specimen, or once we remove this tumor or mass, what have you, what comes next? What comes next in the pathological diagnosis of our patient, and how does the pathological diagnosis change our management?
And that's a good thing to bring up because I personally, and maybe for people watching this, I wouldn't immediately think to do a pathology rotation if I was interested in doing surgery.
Yeah.
But
So that was the first point of that. And then the second point of doing a pathology rotation is that determinant of where you are, facility wise, you have the clinical pathology side that's doing things like biopsies and, tissue prep. But you also have the anatomical pathology side where you could potentially be involved in things like autopsies or medical legal death investigations, where that involvement, while unfortunate most times because you're investigating why someone eventually, came to the end of their life, it provides you with a lot of anatomical knowledge because it's essentially a cadaveric dissection each time you do an autopsy. And you're becoming familiar with what normal anatomy looks like versus diseased anatomy. You're becoming familiar with when you open an abdomen, oh, does that liver look big? Does that liver look small? Does something look wrong? And you're training your eyes so that eventually when you become a surgeon, you open someone's belly and you can say, that doesn't look right. I need to investigate.
Okay. Yeah. And I can immediately see the impact of that being that, you know, uh, I didn't actually know when I had applied at Ross that we didn't have cadavers. And so, you know, it is what it is. But
Right.
looking back on it, I wish we did, because not only is it sort of a rite of passage sort of thing, it's also, especially if you want to go into general surgery, like super helpful to know where everything is. And I mean, of course, we read about it, like, you know, we know that extent of it, but actually seeing firsthand with your own eyes, I think is really, really important. So, wow, that's something I wouldn't have thought of. Yeah.
Yeah, and seeing that anatomic variation, because unfortunately our patients are not textbooks.
Right.
So
Right.
you could get into someone's abdomen and find all kinds of weird things. You could get into someone's neck and find something you never would have expected. So it's just those things that I thought that rotation would be beneficial in training me to see variation in anatomy and to appreciate that variation.
Okay.
Yeah.
Awesome. So
Then
after pathology, what comes after that?
So after path, then I'm doing emergency medicine. And
Okay.
again, I think that that's a great rotation to have because it teaches you how to deal with high acuity medical issues like, MIs or PEs, DVTs, trauma, things like that. And as someone that's kind of a trauma junkie and wants to hopefully break into that field, that was a way for me to both broaden my horizons in that field, but also meet my medicine requirement. So that's kind of my reasoning behind choice. After EM, I then go to neurosurgery, where frankly, the brain scares me to death. Being a neuro, it just does. Like I have this weird thing with the brain that's just like, you know what, neurosurgery for me career-wise is just not the move because I am too much of a perfectionist and it's my luck that, one day one little tiny thing would go wrong and then I give someone's grandma back to them and she's no longer their grandma mentally. Like I just don't know that I could live with that. But my reasoning to do that rotation was because, again, when you think about traumatic injury, you think about injuries to the abdomen, the thorax, and the head as like your major problems.
Right.
As crude as it sounds, if you have a badly damaged limb, you can amputate it. You can't amputate someone's head. So, not really going to go well for anyone.
No, it wouldn't.
So becoming familiar with how our neurosurgical colleagues manage traumatic head injuries, especially things such as like epidural hematomas, subdurals, things like that are really common in your like motor vehicle accident patients, and managing that from the trauma perspective with our neurosurgical colleagues, I wanted to gain more insight into their side of the management. That way, eventually, I can hopefully become competent enough to say, hey, we're outside of our scope now. Let's call the neuro people in and let them do their deal. And then after they're done, we'll take it from there.
Absolutely. Yeah, I think I get what you're saying as far as like the neurosurgery, because it's like crazy to me, especially I watched what was the show they had on Netflix where it was talking about these neurosurgeons and like, oh, the Lenox Hill. If you haven't seen it, I would go check it out.
Yeah.
So they follow a bunch of different doctors, but there's two like neurosurgeons they follow, and it's always crazy to me how they'll be in a case and they're trying to get rid of a tumor that's in the brain, and they'll be like, well, at what point do we take out tumor so that we don't actually take out brain, and where do you make that, because it all looks the same really. And so it's a pretty that's a pretty daunting specialty to go into.
Yeah. It's funny that you mentioned Lenox Hill, because for a while, the neurosurgical staff at Jamaica Hospital was coming from Lenox Hill, and they would do a rotating call schedule at Jamaica. And one of the surgeons who was instrumental in creating the Netflix show Lenox Hill actually came and like gave us a talk, and it was really
Whoa.
cool to get to. It was really cool to get to like meet him, hear about his experiences, hear about like he talked a lot about like the future of surgery, the future of medicine, what's coming down the pipe as far as like new technologies, and it was an incredible experience, and I'm so glad that I got to meet with him and hear that.
And I'm jealous. Yeah, like just hearing that. That sounds like it was a lot of fun.
Yeah, yeah, amazing. Then after neurosurgery, uh, I'm then doing minimally invasive and bariatric surgery.
Okay.
Again, choice behind that was pretty simple. That's like one of your that's one of your bread and butter general surgical specialties, because MIS, you're doing everything from, lap choles, robotic choles, lap appies, robotic appies, lap and robotic assisted colectomies, things like that. These are everyday general surgical and like colorectal cases that you're being taught to do in a fashion that's better for the patient's healing. And then in addition, getting the extra bariatrics experience that, you know, again, unfortunately, the United States is in host of an epidemic of metabolic syndrome, obesity, hypertension, diabetes. And data has shown over and over again that these bariatric surgeries are life-changing for individuals with severe metabolic syndrome. And once they're able to undergo surgery and then follow a proper diet and exercise plan, they can reverse these medical problems and go on to live a very healthy life. So that's really interesting to me as well, is just getting that additional experience there, because I feel like that's going to be a large portion of like what general surgery is doing moving forward, is handling those types of things.
Okay, awesome. Yeah, that's yeah, I actually had a laparoscopic appendectomy. This is like, I don't know, maybe 2014, 2015. And so I don't know why, but at the time I wasn't in medicine at all, but I came out under the assumption I was going to have these giant scars, and then when I came out, I just had these little tiny little three little pinpoint, and so like I can't even find them anymore. But
Yeah,
that's a good rotation choice. Yeah.
definitely. Then after that, I'm kind of keeping with the same theme and doing GI.
Okay.
Again, GI for the same reasons that I discussed earlier, just that medical management of things like, you know, hepatic disease and, gallstones, because you can medically manage some of these things.
Yeah.
Medical management of appendicitis, which is a new thing. If you haven't read up on it a whole lot, I suggest you read up on it, because so many people still assume that surgery is always the answer for appendicitis. Hate to break it to you, it's not.
Mm.
Yeah, and then getting experience in reading different types of GI studies, like whether that be a barium swallow or a barium enema, or getting to experience like doing ERCPs and seeing how they do things like pancreatic duct stents or biliary duct stents. That way, when I encounter those in my surgical patients, I'm familiar. I'm like, oh, I know how they placed this, why they placed it. Cool, let's leave it be, or hey, I'm fixing the problem already, we can take this out. That type thing.
Okay. Yeah. That's cool. Yeah.
After GI, I'm then doing cardio, because cardio again kind of ties back to like that basic medicine. A large portion of Americans have cardiovascular disease. It is a very common thing that you're going to have to deal with, managing, heart failure and people with coronary artery disease, arrhythmias. Again, once you get into your critical care realm and you've got people on all sorts of vasopressors and inotropes and this and that and the other, and you've got 15 different medications going into this one patient a day, how does that affect what I'm trying to do elsewhere, as far as, are they adequately perfusing their end long enough to do it? Do I need with or mechanical cardiac support? Things like that. And then, of course, you know, everyone needs to know how to read an EKG really, really well.
Sure, yeah.
And I feel like the only place you really learn how to read EKGs like a cardiologist is with the cardiologist. So why not?
Yeah. No, I mean,
Yeah.
just real quick,
And
like
then after
tying
that,
into
I'll
the.
be doing a
Or,
yeah.
oh no, I was just gonna
Jump in.
piggyback off of what you said there. Like, I think that's one of the
Yeah.
biggest, like, I guess things that was shocking, but I guess not surprising, is just your patients you see in a hospital. All of them, it's either heart failure, diabetes, high blood pressure, like coronary artery disease. Like these are so common. So that's
Yes,
that's
of course.
a really good thing to know
Yeah.
all your cardiology.
Yeah, because at the end of the day, I figure that most of the people tuning into this, because it is from SNO, want to be surgeons. At the end of the day, even as a surgeon, you have to be as good as a medicine doctor at managing medical problems.
Yeah.
Because if you're the primary team for that patient, do you really want to call a medicine consult for a blood pressure of 145/90? You'll probably get some nasty looks from your medicine colleagues and be like, why are you calling me for this? Like, you know how to handle this.
Right. You should know.
So, at the end of the day, whether we're surgeons or internal med docs or EM docs, we're all medical doctors at the end of the day. We all went to medical school. We should be able to manage basic hypertension, basic diabetes. So just building that foundation and becoming extraordinarily comfortable with those common medical problems is going to really improve not only your skills as a physician, but it's going to improve your patient's outcomes, because they're not having to wait for a consultant to come in and tell you, give them 30 milligrams of Procardia and call me tomorrow. You can say, hey, we're going to try this, and if it doesn't work, then we'll call a consultant in. Your patients are getting earlier interventions. Most of the time, they end up started on less medications. They have less post-operative complications because their medical problems are managed.
Right.
So these are all things to be thinking about in building your career as a surgeon.
Awesome.
And then my final rotation that I have scheduled up to this point, because we can only schedule up to a certain point,
Okay.
is
I didn't know that.
yeah, and I'll touch on that, is plastic surgery. Plastic surgery, to me, like when people think plastic surgery, they think like, Beverly Hills 90210, botched, things like that, like all of this cosmetic stuff. And while that's true, and while plastic surgeons do amazing jobs at cosmetic procedures, they're also really vital in complex reconstruction procedures for, accident victims or burn victims. A lot of your burn patients are managed by plastic surgeons that are also, mentally really good medicine doctors and know how to keep these people fluid balanced properly and know how to maintain proper wound healing over 75% of someone's body surface. Like, that's incredible.
Yeah.
That's amazing.
Sure.
And not to mention, no surgeon wants the reputation of being a butcher. And I mean that to say this, is that when a patient comes to you and wants to have a surgery done, they don't see what you've done on the inside. They don't see that you removed their gangrenous gallbladder that was filled with, huge cholesterol stones. They don't see that you alleviated them from, ulcerative colitis by doing a colectomy. They see the scar.
Yeah.
So if their scar isn't pretty, the patient isn't satisfied. And sometimes you can't make a pretty scar, because sometimes you're just trying to keep somebody alive. And at that point, you probably shouldn't be worried about your scar. You should probably be thanking your lucky stars that you're like going home.
Or you can still be upset about the scar.
But by and large, you can still be upset about it at the end. That's fine. That's fine. That's fine. Like that's between you and whoever you pray to.
Right.
But my point being is that I want to gain those, really good aesthetic skills from our plastic surgeon colleagues. That way I can make my patients look as untouched as possible after I finish operating on them, and they go home and they're satisfied and their illness is resolved because we've taken care of the internal pathology, and they're still confident enough to, go to the beach without putting a shirt on, or go to the beach in, a bathing suit because they don't have this big, ugly, nasty scar.
Right.
So that was my rationale behind that choice.
Okay. Cool.
Yeah.
Yeah, it sounds like a solid year you got set up so far.
Yeah, it's going to be super stressful, but I'm really excited about it. And then, of course, amongst all of this, like studying for and taking step 2, preparing applications and interviewing, and it's going to be a lot, but it's going to be well worth it at the end. I know that we all know that. We've been told that so many times. Just keep going. It'll be worth it in the end.
Yeah,
I promise.
No. One of the surgeons I was working with at Jamaica, he is a Ross alumni. I just kind of bumped into him, and turns out this is his first job, like first attending job. So he basically went through general surgery, did his fellowship, and this is his first job. And one of the things I asked him was like, what's it like? Like you're done, like you're established. What does it feel like? And he was like, it it's really good. He had like a very sort of like that like relieved, or I guess resolved look of like, I finally made it kind of thing. So yeah, this is all just one step in a journey of many steps. So
Exactly. Yeah. So Stephen, if we can, I want to talk a little bit about what the application process for electives looks like.
Yes, please, because I don't have any knowledge of what that's like.
Yeah. So there's a lot of different ways to apply for electives. The first way and the easiest way is through the affiliates that schedule via the Ross online scheduling portal.
Okay.
So
these are Ross affiliated programs, correct?
Exactly. These are for Ross affiliated programs. So the way that this normally works is that I think that it's after you complete 3 core rotations.
That's what I was told.
Yeah, they send you an email that says, hey, you're in this semester priority level. Your scheduling will open on this day.
Okay.
So then you can log into the system and choose whatever electives are available. Now, keep in mind that the people that were priority ahead of you, so like if you're a third year that's just finished your 3rd core rotation, you're going to have 4th year scheduling ahead of you. You're going to have people that are at the end of their core scheduling ahead of you. So there may not be a ton available. Fear not. Do not panic.
Right.
Because here's what happens. There seems like there's not a lot available, but as you get closer to these start dates, a lot of people will change electives, or they'll get an opportunity somewhere else and they'll drop that elective. So you can add yourself to the wait list. That way, if someone drops it or chooses to do something else, you can slide into that spot.
Okay.
If after all of that, there still isn't enough to round out your year, or there isn't enough to round out, the little bit of time that you're wanting to schedule, you can always contact Ross affiliate hospitals that don't schedule through the online system, because they schedule individually through that hospital. For example, Jamaica is like that. They have a graduate medical education coordinator that you just email her and say, hey, I'm interested in doing electives in X, Y, or Z. Are these available and at what times? And you personally work with that person to develop a schedule based on their availability. And then they just email Ross and say, hey, I talked to Nathaniel about scheduling this elective. Please put it on his schedule. And they do it.
Yeah. Okay. I think I know who that person is too. Got it.
Yes.
So, yeah.
Yes. The other option is, this is the more difficult option, is you can apply for rotations at non-affiliated sites. But so as it stands right now, Ross does not have access to something called VSAS, the Visiting Student Application Service, through the AAMC. A lot of programs, especially larger academic programs, your University of or blank state university, whatever, they're going to require students to apply via VSAS for any elective there. If you do not have VSAS, it is very unlikely that they will accept you for an elective. I will say this, email them. If you're really interested in that program and you really want to be there, email them, explain the situation, send them a copy of your CV, send them a copy of your step 1 score, send them supporting documents to say like, hey, I'm valuable. Please help me out.
Yeah. Self-advocate.
Yeah, self-advocate, exactly. Sometimes they will. More often than not, they won't. But I live by the old philosophy is if you don't ask, the answer is always no.
And closed mouths don't get fed, right?
Exactly. So even if the answer is no, reach out anyway. At least they have seen your name before. They've seen your information before. So maybe whenever you go to apply for residency there, they'll be like, huh, this person was interested in our program, but we couldn't offer them an elective because of X, Y, or Z. Let's take a look.
Yeah.
You know, you're getting your foot in the door some kind of way.
Yeah.
The other option is there are certain hospitals that do not require VSAS to apply for an elective. They do like their own like paper applications and things like that. Definitely apply for those, especially if it's a program you're really interested in, because there's no harm in putting out a quick little PDF application and attaching a cute little headshot of yourself and a resume. Like, it's easy. It takes you 10 minutes. And at the end of the day, you can get a really great rotation. You can form a really good bond with the residents and the PD, and then maybe get a residency out of it. Who knows?
Yeah.
A side note on Cleveland Clinic, Florida. They are considered a Ross affiliate.
Okay.
You can schedule certain electives. You can schedule certain electives with Cleveland Clinic through the online scheduling portal. However, there are more electives available than is what is offered through our scheduling portal.
Huh.
You just have to go to their website. Yeah, their website, and you have to fill out the paper application. That's it.
Okay.
It's a 1-page application. It has very clear instructions on if you want to rotate at X time, you need to submit by this date. And like when I did it, I sent them the paper application. I sent them a copy of my CV. They asked for like a couple of little health documents. And then I heard back from them within like 3 weeks.
Okay. Is that sort of how long it would take normally for them to get back to you? It's going to be about maybe a month turnaround time is generally what I've heard.
Yeah, most places that I've seen or applied to personally, it's like they want to take like 4 weeks or so in order to give you a response.
Okay.
Yeah, generally about 4 weeks. One more note on non-affiliate electives.
Okay.
If you rotate at a non-affiliate, let's say, CCF is a Cleveland Clinic, is an affiliate hospital, so you can just get charged through your regular student aid like normal, like if it was your course.
Okay.
But let's say you apply to, just pulling a name out of a hat here, like NYU or somewhere like that, and happen to get accepted to an elective. First thing, good on you.
Yeah.
Second of all, is that the way that works financially is that you have to pay out of pocket for a non-affiliate elective for the cost of that entire rotation.
Mm.
And that varies by institution. From what I know, it's generally anywhere from $1,000 to $1,800 a week.
A week. So if you're doing 4-week rotation,
you're looking at least $4,000 to $6,000 at the minimum.
Out of pocket.
Now, when you complete the rotation and get a grade, you can submit a reimbursement request to Ross and they reimburse you that money. But just know that you have to front the cost, but you'll get it back on the back end.
Okay, that's really important because there are programs I've looked at where I just thought, we all have unique financial situations, but I think by and large, most of us, anyways, this is sort of being funded just via loans, and so
Exactly.
like $4 grand to just or 4 to 6 grand to just toss up for one rotation, which may or may not be you may or may not get a residency out of it.
Right.
That's a lot to pony up. So
Yeah.
I had no clue. I thought that was just a sunk cost.
Yeah.
That's good to know.
It's a big financial risk, but I will say this. If you are really passionate about that program or you're really passionate about making contacts in a particular geographic area, because that's where you're wanting to match, because that's close to family or close to home or close to a partner or what have you, that
Us being
may be,
from Texas, right? Yeah.
yeah, that may be worth it for you. That may be worth it for you.
Okay.
What I would recommend is that if that is something you plan to do, while you are either like still in basic sciences even or early on in third year, squirrel away a little bit of that loan money that you're getting every month if you can afford to. And I will say this, even living in New York, like yes, money was tight based on my loan money, but like I wasn't ever like in dire straits to where I couldn't save aside a little bit.
I agree.
Just
I agree.
just like sweep a little bit to the side into like a little savings account or something. That way, when it comes time and you want to do one of those electives, you've either saved up enough money to front that cost and then get a reimbursement in a a comfortable financial manner to where you're not going to have to eat like cheese and crackers for 3 weeks.
Can of beans or whatever. Yeah.
Right. Or alternate option is that you have saved enough money to kind of offset that cost. That way, it's not going to put you in a bind.
Yeah. No, I would advocate
So that's
that as
just
well.
my
Like,
kind of 2 cents on if you're really passionate about doing something like that, you need to plan.
yeah, no, 100%.
Yeah,
Especially even living in New
plan
York, you can
ahead.
do that.
Yeah, plan ahead, plan early. And then, I will also say, each person's financial situation is different. But if you're in a situation where you have somebody that you could ask for a little bit of help to front that cost for you and say, hey, I'll get it back to you, and they're willing to do that, by all means. Like my dad always had this old adage of use other people's money first. Use other people's money first.
Right.
So like again, I know that everyone's situation is unique, but if that's something available to you, that might be something to consider as well.
Yeah, I mean, if you can ponying up 4 to 6 grand for, I don't know, 6 months is a lot better than looking at it as a sunk cost, which is generally, again, what
Exactly.
my thought
Exactly.
is. Okay, just
Exactly.
really quickly. So what is
Yeah.
it? What's it like putting together your application? I know you still have some time, obviously, because you haven't started your fourth year yet, but you certainly, I would imagine, have to start kind of get the ball rolling. Like, where do I want to apply? What is my application going to look like, et cetera, et cetera. Obviously,
Yep.
big focus is these rotations and then
Mhm.
doing well on step two because
Yeah,
scores open doors. But give us kind of a little quick
of
rundown
course.
as far as like what your application is looking like.
Yeah. So I'll start with like where I'm deciding to apply
Okay, yeah.
is I don't really have any big geographical ties. Um, as far as like going back home to Louisiana, I wouldn't be upset with that, but that's what I'm super passionate about personally. Um, so I'm definitely going to apply there because, home state advantage,
Yeah.
um, going back home. But I'm pretty much applying nationally. So what I decided to do was I used Residency Explorer, which is a tool that you can log into through your AAMC account that you probably had from when you like took the MCAT or something, that you can sort residency programs, and it's any residency program. They have anesthesia, they have surgery, they have gyne, they have thoracic surgery integrated, like all of these specialties.
Yeah.
And you can choose whichever one you're interested in, and you can filter the list of programs based on what percentage of their residents are IMGs. You can put in your step one and your step two score. and it will tell you if you're in the kind of middle of the road, top 25%, above their average score, bottom 25%, that type of thing. So from there, you can kind of gauge, where am I likely to match?
Okay.
That's the most important thing, is that the worst mistake you could make is by going unmatched.
Yes.
And not going unmatched because of, an application flaw, or going unmatched because of a fluke on a board score, but going unmatched because you simply didn't do your research. So dig in and find, where are our Ross graduates matching? Beyond where are Ross graduates matching, where are our friends from AUC matching? Where are our friends from SGU matching? Because those institutions are generally IMG friendly. And we do have to take that into consideration, is, going to an institution that has a history of accepting us.
Right.
Also, go ahead, Stephen.
Oh no, I was just gonna comment on that, because that's something that I've actually looked at as well. Just looking at, because I'm actually from Houston, Texas, and so the big part of the big conundrum for me is, like, I kind of love it here in New York. So do I go back to Texas? Do I stay here? But one of the things I have been doing is looking at programs, particularly some in Houston, and you have to sort of be realistic in your expectations of, if you're looking at a program, you can look and see what their residents, what do they look like, and do they look like you, and are they from the same place you are? Because if you look through, maybe let's just say, a general surgical residency, and you see all the residents, right? And then the PGY ones all the way to the fifth years, and you don't see a single Ross, AUC, or Caribbean school, that should kind of tell you that maybe that's not the best use of your time and energy. You can always be the first, but lies, damn lies, and statistics, as they always say.
Correct. Now, I will say that my strategy, as far as like that type scenario, is I would break up your application into, 25%, 50%, 25%.
Okay.
Apply, if you're going to apply to, let's just make it like, some round numbers, 100 programs. Apply to 25 programs that are a reach. They're really good programs. You would love to be there. They may not have had an IMG, or your board scores may be a little bit out of their range. But if you could get in the door and get an interview and wow their socks off, and they choose to take you, you would be elated. You would love to be there.
Right.
The bulk of your application, apply to about 50 places of that 100 that you feel like you're a pretty solid, middle of the road, if not advanced applicant for that program. That you feel pretty confident that you could, based on your scores, based on being an IMG, all these other things, that you could get an interview. And then apply to the 25 programs that they may not be your first choice, they may not be fantastic, but you are a solid candidate without a doubt, and you feel like 90% confident that they'll grant you an interview and that you could match there. Because what did I say earlier? The worst thing you can do is go unmatched because of poor planning.
Yep.
So that's kind of my strategy there. You also have to decide if you want to apply to more academic programs or more community-based programs. I will say, kind of like I said earlier, the bigger academic programs generally are not very IMG friendly. There have been cases of IMGs matching there. They love it there. They do great. So don't count it out if you're somebody that's super interested in academic medicine or research or an eventual teaching career, those types of things. But know that you can get some of those same experiences in a community-based residency that might have a university affiliation. That maybe they're not, the big flagship hospital for that university system, but they're affiliated. So you get to rub elbows with some of those people. You get to make connections with some of those people. You get to maybe rotate at the bigger facility for 4 or 5 of your rotations, and you get to experience that. I think that that's a great way to bridge the gap. Furthermore, I want to compound on what you were talking about earlier, Stephen, is look at that program. look at the pictures of the residents and do they look like you? Is that residency program somewhere where you think that you can be comfortable based on a multitude of factors? It could be like an ethnic racial factor. It could be a cultural factor. It could be a
Even
social
gender,
group that you
even
belong
gender,
to
yeah.
that's gender. Exactly. It could be a social group like gender, or it could be a social group like religion, or if you're part of the LGBTQ community, things like that. Like, you want to ensure that you're not going to end up in a place where, even though you might get good surgical training, if you're, you know, the standard 70-kilogram man, to use like an anatomy and physiology textbook example, what about the education that you're going to get if you're not that person? Are you going to be looked at with the same amount of respect? Are you going to be treated fairly? And ensure that when you talk to the residents during interviews, that you find residents that resonate with your values, and that you find attendings that resonate with your values. Because the only thing worse that I can think of than not matching would be matching somewhere that I hated for the next 5 years because there was
Yeah,
nobody that looked like me, or there was nobody that had the same views as me, or there was no one that was accepting of, some part of my identity or lifestyle.
right.
So just keep that in mind as well. Keep that in mind as well.
Absolutely, because from what I've seen with these residents, like do a 5-year residency in general surgery, and this is just very anecdotal, just from what I've seen so far. It's a slog, and so if you're doing that in an environment that is anything other than you know camaraderie and that sort of thing, I think that you're just setting yourself up for a very, very miserable 5 years. Yeah.
I agree. And don't get it twisted. I'm not going to tell you that everything in surgical residency, at least from my experiences with the residents, is unicorns and rainbows. Like, there are hard days. There are days where you don't want to do it. There are days when you feel dead tired, and the only thing you can think about is going home, eating breakfast, and getting in your bed. But this is the life that we're choosing. This is the career that we want. And at the end of the day, everyone is satisfied with the job that they do. Just make sure that you are surrounding yourself with people that are supportive, that are going to build you up as much as possible and not tear you down and try to belittle you or try to make residency any worse than it has to be.
Right.
Find somewhere that feels like home.
Gotcha.
Find somewhere that feels like you belong. And after that, it's not going to be a cakewalk, but it might be just a little bit better.
Absolutely. And that's also what I would tell people who are, about to take STAP, just finished STAP, like, going into your third year. What I've sort of seen, my takeaways is, really immerse yourself in whichever, core rotation you're doing, because, I personally never really ever saw myself as a pediatrician, but I'm excited to do that rotation. I'm going to give it my all, because who knows, like maybe it turns out that's my calling. I like that instead of surgery. Or for example, for me, it's really interesting to, now that I'm actually doing the surgical rotations, I do like it. And so that's something you have to keep in mind, is like, make yourself as competitive as possible, do everything you can for your career, but go in with an open mind. It could just be that you actually scrub in, like I scrubbed in on one case that, and we did a BKA, below knee amputation, and they pulled out a giggly saw, and then the resident was here, can you hold this side? I was like, yep. He's like, okay, grab the other one. He had to tell me like 3 times because I couldn't understand. I was like, oh, I thought, yeah, I was helping you. He's like, no, you're doing it. I was like, oh, okay. And it could be that you go in, you have that experience, and it turns out that it's not for you. You know,
Yeah.
because like I got to see that procedure done maybe 10 years ago. I was so excited to do it. It's very different when you round on the patient before and you have those interactions and then having to do it. It wasn't quite what I thought it was. for better or for worse. And those are aspects that you're going to miss if you go in without trying to like really take a deep dive and go in with an open mind on those sorts of things.
And to that point, I'm going to point at you with my handy dandy needle driver that I always keep on my desk.
Yeah.
If you think people don't talk, they do. So just because you want to be a surgeon and you know right as rain that you want to be a surgeon, don't think that they won't hear from the medicine attendings that maybe you slacked because you don't want to do medicine. Or don't think that that GYN attending won't see that gen surge attending in the operating room and not talk about your performance in their rotation compared to the others. Build a reputation for yourself for always being interested, always being involved. Learn as much as you can in your third and fourth years, because this may be your only opportunity to ever practice pediatrics ever again.
Yeah.
This may be your only opportunity to ever practice OBGYN ever again. So appreciate those experiences, involve yourself as much as possible, because whether you think so or not, all of those experiences translate to your career and they leave a little mark on your brain and a little mark on your heart that is going to come in handy later.
Absolutely. And, just from just a pragmatic approach, like we're already paying a considerable amount of money that, our future selves are going to have to one day pay back. So, don't even look at the number. It's not worth it, right? So until you start making the money, don't worry about the problem, right? But you only have one opportunity to learn those skills, right? So, and you're paying for them. So if you break it down, I don't want to like break down entirely, but it comes down when you look at the figure of every hour that you're paying to be there. It's a considerable amount of money per hour that you're being there to not give it your all, or not take the initiative, or not learn those skills that would one day. Because like you said, yeah, maybe you don't want to be a pediatrician, but that being able to diagnose a kid with whooping cough is something that you might want to pick up, because you might only see that once. Like we had a monkeypox patient, and I went to go see the patient, because ideally hopefully this never becomes a problem again as an epidemic. But if it does, you're one of the few people that's seen that before and knows how to deal with it, or knows what to look for. So exactly. Yeah, definitely keep that in mind. Like I said, it's your time and money, so don't waste either of them.
So
yeah, absolutely. Go ahead if you were going to say something.
Just kind of in conclusion, is I just want to encourage everyone to continue to work hard, continue to study hard for your board exams and for your shelf exams. I know that it's difficult when you're in the hospital, busting your chops every day, but carve out that little bit of time to study. It doesn't need to be 5 hours of studying a day. It can be just a little bit. That information that you learn in the hospital plus your studying, it all compounds. But more than anything, remember to take at least a few minutes a day for yourself. Check in on yourself. This is a taxing, grueling job that we will be in for the rest of our lives. Make sure that you're taking care of yourself physically. Make sure you're taking care of yourself mentally. Reach out to your family. Reach out to your friends, whether your friends are in medicine, outside of medicine. Reach out. Keep in contact with them, because that's going to be your support system that's going to get you through this. They're going to get you through your last 2 years of medical school. They're going to get you through residency. They're going to get you through fellowship. And then you'll come out on the other side and all of your bonds will be so much stronger because you've endured this trial together. So just make sure that you're keeping all of those things in mind. And to leave you with kind of a quote that I live by is, you can't fill up another person's cup out of an empty bucket. If you allow yourself to be completely drained and completely burned out to the point that you have nothing else to give, there is absolutely no way that you're going to be an effective physician, an effective friend, an effective husband, wife, girlfriend, boyfriend, mom, dad, what have you. because you have nothing else left.
Right.
Do things every day that fill up your own bucket. That way you can continue to fill up other people. And if you ever at any point reach a time where you feel so burned out and so empty that you feel like you need professional help, reach out to the RUSM Counseling Center, reach out to a local resource if you have one, reach out to a friend, reach out to me. I don't care. Reach
Yeah.
out to someone, because at the end of the day, you are valuable and you matter, and people want you here, and we want you here in your best capacity. So just keep all of those things in mind beyond being, trying to be encouraging and sappy and what have you. If anyone has any questions, if anyone needs guidance on applying for electives, or hey, if you heard anything about this track or this or that, the other, feel free to reach out to me. I'm on WhatsApp. You can find my email. If 9,000 people bombard me with emails, I might scream.
Right.
But
Not
I
all at
will get
once.
to them. But I will get to them eventually. Um, I love to help out others. I love sharing the experiences that I've had and hopefully making an impact in someone else's journey, because at the end of the day, we're all here to help each other succeed. So I just want to thank you so much, Stephen, for having me today and for allowing me
Absolutely.
to share my experience with everyone.
Absolutely. Like I said, this is our first podcast in a series, basically trying to, shed some light on the not just applying to different residencies, but what the process is like for raw students. Again, there's very little. It feels like there's very little literature out there or resources. So, being able to hear from people in your position that are further along, even for all of us, even for people like me. Is fantastic. You are doing the Lord's work in my eyes. So
No
yeah,
problem.
just wanted to thank you, Nathaniel, for being the first in our inaugural podcast series. So if anyone has any questions about sort of the interviews podcasts that we have, please feel free to send SNO all your questions. We would love to have them asked on here first and foremost. So yeah, with that. Till next time. So for everyone back listening, hope you enjoyed it. Hope you learned something. So, stay calm and go study. And we'll see y'all next time.
Yeah. Take care, Stephen. See you around.
Take care, bud.